And another announcement is starting from next week, we're going to be in 150 downstage for the rest of the semester. So we're going back to pre-pandemic conditions, from where we like. Okay, so it is my greatest pleasure today to introduce our speaker, Dr. Onome Osokpo, who is a Provost Postdoctoral Fellow, Postdoctoral Research Fellow at the New Portland Center for Transitions and Health in the School of Nursing here at Penn. Dr. Osokpo holds a PhD from Penn, where he was a CAS Scholar and a Jonas Nursing Scholar and a Fontaine Society Fellow. His dissertation focuses on exploring sociocultural factors influencing self-care among African immigrants living with chronic illness here in the United States. He received his MSN in the Adult and Gerontology Nurse Practitioner program at Penn and his BSN from Stony Brook University. Dr. Osokpo is also an adjunct faculty at the School of Nursing at Penn, and he previously served as a member of the Diversity Committee of New York State Action Coalition, and he is also a consultant and presenter for the Philadelphia Corporation of Aging, where he develops and delivers evidence-based disease prevention and health promotion talks to older adults at senior centers within Philadelphia. Dr. Osokpo's research examines individual, cultural, social, and structural factors that affect self-care behaviors and access to and use of healthcare services in the United States. And his goal is to develop culturally concordant interventions that integrate behavioral economics and culturally tailored strategies to improve the lives of persons with chronic illness. With this, please join me in welcoming Dr. Osokpo.
Yeah, thank you everyone. I'm so happy to be with you today and to talk about the work I'm very passionate about. I want to begin by saying a big thank you to Diana and to, I'm sorry if I mess up the name, the director of the center for giving me this opportunity. So what I would like to do in the next couple of minutes is to give you an insight into some of the things I think about, the work I care about. And hopefully by the end of the session that a fire will be kindled in your heart. So that's the big picture for me. The big picture is people will leave this session with a passion to make a difference in wherever context you find yourself. And hopefully you can draw some inspiration from my own context and what I think about. All right, so today I want to give you sort of an inside look into the self-care behaviors of African immigrants living with chronic diseases. So what I will do in the next few minutes is I'll tell you a little bit about my personal and professional background. Then I will call your attention to two studies I've done and some of the lessons learned. And hopefully we'll have some time to take questions. So I came to the United States in 2006. Prior to coming to the US, I was an analytical chemist. So I did a bachelor's and a master's degree in chemistry. I graduated from the University of Ibadan. It's the first university in Nigeria. And coming to the US, I wanted to pursue a PhD in chemometrics. My first interaction with Storybook was to investigate their PhD program. Like with most immigrants, I decided to get busy. So I got a job working in a food lab in Long Island. And I needed a second job because I had commitments, you know. So I picked up a job at a place called United Cerebral Palsy of Greater Suffolk. While I was there, I was still kind of in the process of getting into a PhD program. But that was sort of a defining moment for me. You know, after my first year working with these individuals with cerebral palsy, non-verbal, you know, something inside me clicked. Because when I saw people who couldn't communicate smile, you know, express joy, I just thought, hey, I don't belong in the lab. This is what I should be doing. To cut a long story short, I started my journey in the healthcare space. So I went to Stony Brook, I did my BSN. I started to work in the medical ICU, spent some time, and I did a couple of work in medical surgical unit, step down ICU. While I was at Stony Brook, I was selected as a Robert Wood Johnson Foundation scholar as a nurse. So that gave me some international and national exposure. And in some of these conferences and meetings I was part of, I was inspired to pursue graduate studies. So I started what we call a DNP at Stony Brook, a Doctor of Nursing Practice program, where nurses are trained to be expert clinician. But I felt I needed a component that allows me to do research and generate knowledge. So I came to Penn. So I stopped after 1 year in the DNP program. I left. I came to Penn so that I could maximize my education. I completed an MP program, a Master's in Nursing Science program at Penn. But immediately I went into research and teaching. So I started working as a faculty member. I spent some time also at Whiteman University, while I was also doing some work as an outpatient clinician. Then I transitioned to the PhD program, and yes. So when I think about the work I do, one of the things I try to call attention to, sometimes in the clinical and political space, we blame culture for so many things. We don't think of things from an asset-based perspective. And my work is to kind of help people think about things differently. So I look at, you know, chronic diseases and chronic illnesses based on these three interconnected framework, right? I think about the social factors at play, the cultural factors at play, both the implicit and explicit dimensions of culture, then also the individual factor in the picture. And one thing I will call your attention to right away is the structural factors are powerful to eliminate any cultural assets that might exist. That's something we need to think about. You know, even when cultural assets exist, structural forces are very powerful to eliminate those assets. And we'll talk a little bit more about that. So, I mean, generally, I'm thinking a lot about social determinants of health, but not just there. What do we do? How do we intervene? How can we bring about evidence-based strategies? You know, so broadly thinking about minoritized and marginalized communities. Just to give you a sense, perhaps which you already know of why this might be important to every one of us in this room is, in 1980 you had about 130 African immigrants in the US. As of 2018, you have 42 million, right? And when you think about that population, there are certain interesting things to think about that population. The fastest growing immigrant population in the United States, highly educated, but we interest you that the education doesn't translate to better economic returns. So yeah, I just wanted you to kind of look at that. I want to think about the top countries of origin of African immigrants in the US. Yes, thinking about countries like Nigeria, Ghana, you know, Ethiopia, Liberia. And when you think about, you know, just the New York, New Jersey, Washington axis, over 200 or about 300 1,000 African immigrants are just in this area. You have a sizable chunk also in Atlanta and in Minnesota. In Minnesota, you see a lot of Ethiopians. But in Pennsylvania, for example, you see a lot of Nigerians, Ghanaians. And when I get to my work I did, I focused my work at this time just looking at residents of Pennsylvania, and I'll tell you why. Because of the differences in how policies play out within a political landscape and how that can impact the health and well-being of African immigrants. So I wanted to get a good sense of what's going on in the context of Pennsylvania. So again, as we begin to think about some of the issues with African immigrants, I want to just reflect on what you see on the screen, some of the linguistic language challenges, right? I came in as a young adult, and I cherished my accent. You know, I was educated within the British context where you emphasize your consonants, right? There's a way you speak, and sometimes speaking English doesn't mean communication is taking place, right? So we have to think about those linguistic challenges. It's not just about are they able to speak English or not. That's too simplistic, you know. Even when we communicate with English, it's still exchange of information. We need to think about that. Then this idea of being culturally attuned to the population, right? There's a lot of lingo we throw in the healthcare space. We talk about cultural competence. We talk about cultural humility, right? And now, you know, I guess the buzzword is being attuned, right? How do you really maintain a posture where you're sensitive to the needs of the people and you're intentional in trying to understand the needs of the population? Then I talked about poor economic returns and you know, restrictive governmental policies, and that differs by state, right? So that differs by state, and that's something to think about. Then this idea of double jeopardy, right? Being black and being an immigrant, right? Being black, when you look at in the context of disease profile, you know, the black population are disproportionately affected by disease conditions. How does that play out into the black immigrant population? It's a different conversation. But added to that, now think about immigrant-specific challenges, right? We talk about social determinants of health, but I think we also need to think about immigrant-specific social determinants of health, and how that comes into the picture. Now getting to the core of my topic on chronic diseases, right? This is what we know so far, that the rates of chronic illnesses is rising among African immigrants, right? I gave you something to think about. When you think about all immigrants in the US, African immigrants are 3 times likely to have diabetes. Then when you even adjust for age and gender, you are seeing that in the population about 20% have hypertension. Self-care is critical in illness management. All right. So when I talk about self-care, I'm not talking about ADL, activities of daily living. Right? Self-care as a concept, and I subscribe to the middle range theory of self-care of chronic illnesses, where self-care is defined or thought about as behaviors that people perform to maintain health and minimize illness complications. There are 3 core domains of self-care. You have the self-care maintenance, you have the self-care monitoring, and you have the self-care management, right? So self-care maintenance, think about it as the behaviors to maintain health, right? You eat the right recommended diet, you exercise, you sleep well. Think about self-care maintenance. Self-care monitoring has to do with labeling your symptoms, interpreting your symptoms, right? And there's a lot of work around, illness perception and interpretation and the concepts of illness, right? So, and you have to think about in the context of the population how we do that. Now, management has to do with the behaviors, the action in response to your symptoms, right? I feel short of breath. I call my provider. I feel short of breath. I take a pill. Those behaviors are what we describe as self-care management. Now, one important point is I'm talking about chronic diseases and there's a whole profile. I guess the question in your mind is, can we think about, are we thinking about this right? Shouldn't we be thinking about it in the context of disease specifics? One exciting thing about this tool is there are commonalities, core commonalities across disease conditions that helps us to capture self-care, right? Irrespective of the type of illness or the state of the illness. So I just wanted to call your attention to that. So I'll talk about this study I did to kind of help frame the work I'm doing, to kind of see what's out there and help put things in a proper perspective. So it's published in the Journal of Advanced Nursing, where I was exploring the influences of culture and self-care. I wanted to understand and identify cultural factors influencing self-care in this population. And I'll tell you a little bit about this study. So I did what is called a systematic mixed studies review to kind of get at what's out there. So this is not a systematic review, and this is not an integrative review, right? This is a method that sort of reflects a mixed method approach, where you're looking at the quantitative data separately. That's your first stage of synthesis, and you do that narratively. You're looking at your qualitative data separately. Then at the third stage, you are integrating so that you can get a whole picture of what you're doing. So based on my aim, I wanted to include primary studies that examine the influence of culture or dimensions of culture. I mentioned earlier, there are explicit dimensions, and there are, implicit dimensions, right? And related to chronic illness, adults, and that had African immigrants. This is just a prisma diagram. So this is what I found. I found that so when I did this, I didn't place any limitation on this. So most of the work I saw that met my inclusion criteria were published between 2006 and 2019. You can see on the screen that the contexts were primarily diabetes and hypertension. We have studies looking at Somalians, Ghanaians, or some who just generally say West African immigrants or Sub-Saharan African immigrants. And you see the duration of residency. One of the things I want to call your attention to is the conceptual framework. There's a lot of work being done out there where it's not informed, it's not anchored by conceptual framework. And you can see from the studies included, only 4 used a conceptual framework to guide their work. Now, like I said, there were 3 stages of the analysis based on the design. So the key message from the synthesis of the quantitative studies was cultural expectations and experiences were driving the self-care choices that the African immigrants were making. And when you think about the qualitative studies, we begin to gain more insights, how we think about how African immigrants manage their chronic illnesses, use of herbal remedies, cultural norms regarding physical activity, right? Oh, you have a question?
I have a quick question.
Okay, go ahead, please.
What does culture mean here, or how is it measured?
Okay.
I also find it very difficult to
Okay.
figure out how people measure culture.
Okay. Yeah, so culture are shared norms, shared values, shared ways of thinking that a group of people espouse that informs the choices they make, the way they live. I think the key word there is shared. Shared norms, shared values, shared ways of thinking, right? This idea of an internal cultural logic, how people look at the world, the schema in which they look at the world, right? So that was the definition that anchored my inclusion criteria. I hope that's helpful.
Yeah, I just wonder how it was measured in the study, because I found that it's often just the fracture or...
Yeah, very good. I'm going to talk about, so I apologize. No, that's it. So in many studies, people use proxies of culture, and I'm going to get to that.
Okay.
And there are several proxies of culture people use, right? Even sometimes as simplistic as ethnicity, right? That's a simplistic. Are you African immigrant? And that's equated to mean culture, right? If somebody says I'm African immigrant, they say, okay, that's the culture, right? So that's simplistic. Culture and that's why in thinking about if you're going to do some work in this space, it's, from my perspective, it's very insufficient to explore these factors using just a quantitative paradigm. Mixed methods approaches are best and most suited because it allows you to have sort of a comprehensive framework, and we can have a conversation about that as we continue. Right, so I talked about some of the things you see at play here. I'll call your attention to, I know I'm jumping ahead, but I'll call your attention to the importance of family. Right? How do we think about decision making in the context of health? Right? How do we think about it from a perspective of individualism and from a perspective of collectivism? Right? I'm in my early 40s. Right? There are decisions I don't make by myself. I don't make it by myself because of my internal logic. I won't say, well, this is just what I want to do. No, I don't do that. I've not been socialized. I've not been brought up that way. I operate with a collectivist framework. But that's different from someone perhaps who grew up in one of the Western contexts, right? Where we say, well, this is what I want to do. I'll go ahead and do it. So when you think about my health, family plays a role. So family decides, should we proceed with this medication? The community has a role. When I say the community, there are heads of communities, elders in the communities that have, in many instances, are not related to the individual, but these are powerful influences that people consult in making decisions. So that becomes an asset that we can leverage to help the individual as we think about self-care. So it's not just self-care in the context of I do it myself. So there are dimensions. In fact, I see a lot of research that is based on the dyadic framework, the person and the care provider. And I find that also to be a little bit simplistic. But you see this idea of body listening, body cues. My body tells me I need to take a medication, right? Not necessarily, because I need to respond. I know when my body is speaking to me. So that you see in the context of self-care monitoring. Then there are tailored approaches. But one key point I wanted to call your attention to is cultural influence is not isolated. And that's what I started to talk on. Many of the individuals in this study that I reviewed called attention to the fact that, many times I want to do this, but I don't have this. So there are structural factors that get in the way. This idea of maintaining cultural identity, right? Thinking about, even though I'm in this context, I'm an African immigrant. There's a way, there's a type of food we eat. There's a way we live. There's a way we think about how we respond to illnesses. And one caveat, one caution I want to say here, especially for people, perhaps, many times you think about what's the reference. We need to be very mindful of that. The question is, how do we decide this is the reference, right? Is it based on a Euro-Americentric reference point? We need to think about that. How do we decide this is healthy, this is right? Outside just the scientific work, right? It's something to think about. I just wanted to put that out there. So I decided, part of my dissertation, to actually carry out a study, right? So the study is still ongoing, but I completed a slice of it so that I can get done with a PhD. And those of us in the PhD program, one good advice I was given, you can't do everything, right? Get done. So I wanted to get done. All right, so I'm going to describe self-care. And one important point is this. Self-care is an aggregate of behaviors, of health behaviors, as an aggregate of health behaviors. Then I looked at relationship between acculturation and self-care. I had a paper under review, and one of the reviewer comments I found interesting was, I talked about acculturation in the paper, but I didn't talk about culture. And the reviewer's point was, I don't say anything about culture. I said, the paper is not about culture, the paper is about acculturation. Two different concepts. Think about culture as more of a construct, and acculturation more like a concept, and there are proxies to think about that. Then I also wanted to explore the social influences of social determinants of health. So I enrolled people in Pennsylvania. I screened for cognitive impairment using a tool called TICS. And one of the things I wanted to get at was this idea that self-care is salient for individuals with symptomatic illnesses. So I did a screening to make sure that those being included, especially when you think about hypertension. Hypertension for some is asymptomatic, but I was very interested in individuals that have had symptoms within the last 3 months. Just so you have that in the back of your mind. I excluded individuals who scored below 25 on the TICS scale. People have asked, why 35? I just went with 35 for a reason. One, that's the age for middle age young adult. And that's the age we begin to see this significant rise in chronic illnesses, right? But my future studies are probably just, most likely include 19 and older. And I believe I commented on why residents of Pennsylvania. So these are tools I use for my data collection, right? I use the self-care of chronic illness inventory. That tool mirrors the theory I described earlier. That tool mirrors the theory, right? It has 12 items on the Likert scale, and you do a little bit of calculation and you convert the score to 100. Clinically, it's been shown that those who score above 70 are thought to have adequate self-care. Yeah, but higher scores in general have benefits. Then I used a modified acculturation scale that was looking at language, looking at media, called the SHASH, I don't know if I'm saying it correctly, SASH scale. It was initially developed for the Hispanic population, but I modified it to kind of test how that can be used for the African immigrant population. I also used a scale, which is not reflected here, called Ronda. It was developed in Amsterdam by someone doing a lot of work with, I'm blanking out on his name, his first name is Charles, doing a lot of work with the Ghanaian immigrants and doing some work also back in Ghana. Then I looked at proxies of culture, and I was very deliberate. Okay, let's think about it based on duration of residency, and also think about it based on age at immigration. Because if somebody came in a little younger, and they've been here 10 years, it's different from somebody who has been here 10 years and they came in here in their 50s or their 60s. So I wanted to also use those proxies. Then those are some of the items I collected from the social demographic form. But I also wanted to look at social determinants of health. Right? Some work has been done that has called attention to some of these variables in influencing outcomes among African immigrants. Yvonne at Johns Hopkins does a lot of work in epidemiology. So she has seen that some of these variables play a role in predicting self-report of hypertension. But I was interested in SelfCare, so I wanted to see that. Right, so these are, those in my study, a sizable majority are Nigerians. You have a large population of Liberians in Pennsylvania. I had sizable number of them in the study. I also had Ghanaians and people from Mali, and I had pockets of other places. You will notice hypertension, many of them, that was their primary chronic disease, and they also reported diabetes. In this sample, you can see the average age was 54. Duration of residency, almost 17 years. The age at immigration, you can see that we had a good number of both genders. Sizable majority of them are married. Just to give you a sense of level of education, right? One challenge, which I'm going to talk about, one challenge I ran into was when I was enrolling, had to do with the political climate, and I'm not going into that. That's not my goal here. But so many people, because of whatever reason, did not want to participate, even though they felt this was good work, but because of concerns about when I was collecting my data. You see that they are gainfully employed, and many of them had health insurance. Now, this is very important. So, what you see on your screen is text, right? Again, remember the Likert scale. They score the item 1 through 5, right? Think about it 1 to 3 as never, rarely, or sometimes perform this behavior. I never do it, I sometimes do it, or I rarely do it. Now, 4 and 5, I frequently perform this behavior. I mean, it's not too surprising that this lowest scoring item is eating special diet. It's not too surprising, I can relate to it. I remember someone was having a conversation with me the other day, someone that joined my study. He had an African immigrant provider and went into his office, and the provider was telling him how you deal with the diet and the rest. He said while he was there, the family member brought the provider his food. And when he opened the food while the patient was there, it was the same jollof rice. So they both started laughing. Like, it's what it is. So the point is this. The point is this, we need to think about the recommendations we make, right? Or when we talk about special diet, you don't just say, go eat this. Because there is a cultural taste preference, right? Food is not just food. Food is symbolic. It means quality of life. It means community. So we need to think about how we make recommendations as providers, right? So how can the African immigrant adapt their diet so that they don't lose their quality of life, the meaning the food brings to them as they try to maintain health. Right? This issue of sleep is also a big one, right? They're not getting enough sleep. Right? But one important thing is the last one I want to call your attention to. That's why I said we should be very careful blaming culture. Right? They all say they do their best not to fall sick. And I can tell you there are implications for staying healthy that is beyond the individual. The person wants to stay healthy, needs to stay healthy, because he lives within a collectivist framework. His success, the money he has is not just for him. He has to stay healthy. So when we say, they are not listening, they are immigrants, they don't pay attention, we need to be very careful with such a narrative, because this says otherwise. So that's self-care maintenance. I'm not going to talk too much about self-care monitoring, but one key thing I'll just mention here is this fact that maybe we need to do a better job providing education around medication side effects, right? Because they say they don't monitor for side effects. So one can speculate or suggest maybe they don't know. Maybe nobody took the time to help them to say, okay, when you take this medication, you need to do X, Y, and Z. But they pay attention to changes in how they feel. And you see that that's the highest scoring. These are individuals who are paying attention to how they feel. They are not negligent. All right, now this is stopped working for me. I don't know. Okay, here you go. Self-care management. Look at the lowest scoring item on the scale. Call your provider for guidance. About 42% or 42% say they don't do that. Then again, the question is why, right? And I can tell you, I can give you insights into why. Because when the possible reason is when somebody is in a collectivist group, they see themselves as part of a whole. The first person they are going to call is not the provider. They want to talk to their spouse, they want to talk to their dad, their mom, they want to talk to their pastor, they want to talk to their imam. See what I'm experiencing, what should I do? Right? So the next thing is now I'm calling my PCP. That's usually not the first thing. I function in that role in the African immigrant community because they know I'm in this space. So they tell me, Onome, I'm feeling somehow, what should I do? Do you think I should call my doctor or not? Do you think I should go to the ER or not? Or the pastor of my local church where I attend calls me and say, a member just called me. The person is experiencing X, Y, and Z. What should we do? So I want us to kind of think about how do we then support this community the best? Maybe we need to think about how do we identify the gatekeepers? How do we work with people in the communities? How do we identify these individuals so that we can better support the community? Oh, go ahead. Please.
So the call your healthcare provider doesn't seem to add up to 100%, but the other columns do. So I'm wondering if there's an answer key missing, or
yeah. Sorry for maybe there was something off, but maybe I missed something there. But I can tell you, maybe it's a typo. I can tell you it was the lowest scoring item, and it scored. That was the lowest scoring item, and this was part of my dissertation, by the way. All right, so I apologize. That's why you're saying this is a duplicate. Now, Sorry, so I apologize. Now, this is the scale. Remember I gave you a number, 70. According to the scale, 70 is considered adequate self-care. So based on what you see on the screen, the African immigrants are doing pretty well. Self-care, self-efficacy is just how confident they feel in being able to take charge of their health. They scored 81. They say, I'm very confident. I can manage my health. I know what to do when I have symptoms. But you will notice that we had a couple of minimum scores. And that's why this study is ongoing, because you are beginning to see that a particular group are not doing so well. And I'm sure you can make guesses already when you think about the demographics that I showed you earlier. All right. Now, when I looked at the association between acculturation and self-care, none was significant. There was no association using a scale, using duration of residency, using age at immigration. So what does that tell us? That tells us it's not a question of how long you've been in the US or what age you came to the US that is influencing the self-care choices. It's not just that. And again, some of the things we've talked about is these scales are too simplistic. They don't give us a robust understanding. And when we think about acculturation, it's a multi-dimensional sort of concept that we can't simplify. That's why, as I will talk, as I progress, I'm currently conducting a mixed method study. Now, when I try to explore social determinants of health, I didn't find any significance, and this is exploration, right? Because if you recall, my study wasn't actually powered for this, but I wanted to kind of explore. I had just eight participants, but I wanted to kind of explore what we might be seeing. Two things that we found significant was education and marital status. And it was only significant with self-care management, response to the illness, response to the symptoms. Somebody who is married scored lower than somebody who is single. And that might not be the guess I will hazard, right? I need to hear more from their qualitative stories. Is the person who is married might want to buy some time to talk with their spouse, talk with other people, but the person who is single says, I need to do something real quick, I'm by myself here. That might explain that. And those who had higher level of education scored had higher self-care scores. So what are some of the limitations of this study? Cross-sectional data, I started enrolling during COVID and the political climate. You will notice that the sample were well educated, and then most of them had reported they had more than enough to meet their needs, and aim 3 was exploratory, right? So conclusion is self-care in this sample is for the most part adequate. We need to investigate further the reasons for poor self-care. Acculturation, not significant. We talked about education and being married. Social determinants of health were not associated with self-care, maintenance, and monitoring. So right now, this is an ongoing study I'm doing. Lessons learned. Go through community leaders. Be transparent when you come to engage. When I was doing this work, I was involved with the Mayor's Commission for African and Immigrant Population Health. I worked with them. I worked with Akana, a group that serves African immigrants, AFAHO. And one of the things they say is people come here, use us, and go. And they say, are you going to do the same? I said, no, I'm part of you. right? So it's important to engage a community and be sincere, be very clear, right? Be very, very clear. Collect minimal identifying information. I'll state that up front because of the political context. You know, we need to be very mindful of that. As soon as they begin to see specific informations, even as an African immigrant, I had a lot of trouble asking those who were elderly about their date of birth, because it's an information culturally that younger people don't ask how old are you. It's culturally you don't do that, right? So that information, I collected that information, but any specific, I mean, I know this is being recorded, I have to be very mindful because it was an interesting situation I had with the IRB, and you know, that you know, to give them the stipend, you have to provide social security number. I said, nobody's going to join my study. How am I going to prove somebody's going to provide social security number to get compensated? All right. So we need to be think about that. Provide adequate compensation. You know, that's very important because these are individuals who are very busy, like I was. Some of them are working multiple jobs. If you want an hour of their time, we need to compensate adequately. If possible, include people, members of that community, and you have them as nurses, you have them as social scientists, you have them as social workers. Include them in your team, right? Include such people as part of your research team, because they'll be able to provide insight as to how to engage and what to be very sensitive about. I remember something happened. One of my students wanted to me to connect her with another African professor that does research in New York on malaria. And she went and was telling this professor, I want to go there and teach them how to use mosquito nets and all that. And the professor was very upset. So what do you think? These people have been doing this before even they've been taking care of themselves. Don't go with that posture of, you know, I'm going to save them. We need to be very careful of that. So I think this is all I've got. I want to thank you for this opportunity to share my work, and I'll take any question if we have time.
Hi, thanks so much for your talk. I have two questions. First, in the sample selection, the inclusion criteria in the study, you noted that English fluency was a requirement. But I noticed that a substantial proportion of your population was either from Mali or Angola, where English is not the primary language, or official language or native language. So my question there is how you think that basically, since it's correlated kind of with these acculturation measurements that you're looking at, you know, how does that influence your sample?
That's a very, very good question.
And then I have a second before you continue. One of the questions that I have is you talk about, and the title of your paper is on these cultural determinants of health. But then you also mentioned that kind of, you know, culture isn't everything, and you allude to structural determinants of health. So I wonder how you're defining cultural determinants of health versus structural determinants of health, and whether or not you see there's any overlap there, or what kind of, how you're basically defining a group of different sets of variables.
All right. I'm sorry if I misspoke. My first paper wasn't anchored on cultural determinants of health. I was more interested in cultural influences. And I think we need to be very careful to separate cultural determinants of health and structural determinants of health, because I tend to think that they operate in separate domains. But let me get back to your first question, which is a very important question. For that part of this study, I had to go with the English criteria because of some limitations, right? Funds, you know, how do you pay for translators and all that. But in future studies, that's a very important component. Yes, because there were a sizable majority that when I attempted to enroll them in the study, they did not meet that being able to read and write. And I really do think that we need to do a lot of work with that population. So that's a point well noted, and it's something I'm thinking about. That's why I've been working with those two organizations I mentioned, because they serve the community. And one of the things that I'm hoping to do is to actually hire research assistants from those organizations, because they also have kind of the framework, the resources to provide interpretation. A good organization doing that, like I said, is AFAHO. AFAHO does a good job, and ACANA does a good job. And the question on cultural determinants and structural determinants, my goal in that first study I showed you was to kind of help. The big picture is this: I want to help providers, clinicians, to be able to think about how to care for these people, how to think about the factors that can come into play as we make recommendations. That was sort of the big picture, to help people think about, when we think about physical activity, what sorts of recommendations should we be making when we think about diet and all of that. But the cultural determinants of health framework, I am not actually engaged that framework in exploring, and my reason is this. I will tell you, for the most part, when we think about that framework, we tend to blame culture. And that's something I'm trying to help people think differently. We can't blame culture. Every culture has assets, has what we call existential factors that are neutral, and we have what we can call negative factors. Every culture, right? So instead of highlighting this group is because of their culture, that's why we see X, Y, and Z. That's something I'm trying to get. But my study on the social determinants of health was more exploratory. Like I said, I did not have enough data. Since my first paper called attention to the fact that culture doesn't operate in isolation, and it can actually neutralize cultural assets, right? I wanted to explore more to identify those factors. I don't know if I've been able to kind of respond to your question. And we can talk some more.
I mentioned this concept of self-care, divided into 3 dimensions, maintenance, monitoring, and management. And for the most part, the items are not things you do on your own. Most of them is how do you interface with the healthcare system. You present your symptoms, you take the prescriptions that they fill for you. And there seems to be a discontinuity between their agreement that they're doing those things and the things they do on their own, like diet and exercise, which is quite important. Yet everybody says in the survey that they're doing the things to make them healthy. So is there a general conclusion you can draw here that people asked about what they're doing to make themselves healthy, they're thinking principally about what they do with their doctor and not what they do outside of the doctor's office? Or is that an inference that's too far?
Yeah, so let me just make sure I understand your question. To get at the concept of self-care, using that framework, these are things usually done by the patient. Yes, the provider makes recommendation about special diet in the context of the illness, makes recommendation about sleep, but the behaviors are the ones performed by the individual themselves. When we say by the individual, that can mean in collaboration with their family, with their community, but not by the provider. So I just wanted to make sure I understand the first part of your question. Is that what you are suggesting?
Yeah, I mean, I'm just thinking the concept of self-care, as I understand it, often I'm just thinking about my students. Like not showing up to class is self-care because they want to sleep in. So, self-care is a whole bunch of health behaviors that in principle can keep you out of the doctor's office. Yeah. But the definition of self-care you use here is mostly, but not all of it, is in consultation with your physician. So it's not things that you're doing necessarily on your own, and you do in concert with somebody else.
Got it. Yeah. So self-care in this context is in the context of chronic illnesses, right? In the context of chronic illnesses, how do you care for yourself? How do you be the boss of your health in the context of chronic illnesses? That's why I provided that conceptual definition, because typically when you say self-care, we are thinking activities of daily living. You know, I clean my room and all that, but no, in the context of chronic illnesses, we are thinking about the things we do to minimize complications so that I don't have shortness of breath, so that my blood sugar doesn't rise, the things I have to do in consultation with my provider who makes those recommendations, the things I have to do to care for myself. So that's what I mean by self-care. And you had a second question, did I think? Oh, that's it.
That's it.
Okay.
No, very interesting. I have two questions. One is, given your experience and your background,
Yes.
you know, there's a tendency in the U.S. that lump everybody that comes from some region together.
Yes.
So is it okay or not to talk about African immigrants in general? Should we be paying more attention to country of origin? So that's one question. The second question has to do with the data and health, and I was wondering if you collected any information about what people report as doing before they migrate.
Yes.
Because you look at a comparison, there's also a way of looking at this, but asking retrospectively, what were you doing before and what you're doing now, and things like that.
Thank you. Those are very, very good questions. So part of my ongoing study is to look at life course, right? The things people have done previously, the sort of behaviors they've had previously before coming to the US. Now, the second question on looking at countries of origin, yes. If we're going to go to the granular level, right, we won't even look at country of origin. But if we go to the granular level, take Nigeria for example, has over 200 ethnic groups, right? Are we going to help the people? Are we going to go to the 200 groups even within Nigeria? So the posture here is looking at things globally. And one of the things I wanted us to think about was that idea of double jeopardy, right? I am black, I am an immigrant. What happens in the space of that intersection? So from this work, I really do think that this can help provide some insight to serve the population. And I tend to think that if we look at other populations of, let's say, whites, and we say all the whites are the same, right? Can we really put all the whites in one bucket? Right? So I guess my point is we don't look at things at a granular level, we look at things at more of the global level. But yes, I mean, when I get more data, hopefully, and I'm able to enroll people, it will be interesting to see Nigerians, Ghanaians, Liberians. It will be interesting. So I think that's a very important point you brought up, right? And yes, it's important for us to look at things from a life course perspective, what they've done previously before coming. All right.
Okay, so it's 9:00 and that's the end of your talk. So thank you so much.